So hello and welcome to this panel discussion to accompany the special collection of Frailty and Stroke in Cerebrovascular Diseases. I think it's a really exciting topic, and hopefully over the course of this discussion we'll be able to give you some insights into what it involves and where the field is going. So to introduce ourselves, my name's Nick Evans. I am a Stroke Association Senior Clinical Lecturer at the University of Cambridge and a stroke physician at Addenbrooke's Hospital in Cambridge. I'm going to ask the rest of the panel, who have extensive experience in this field, to go around and introduce themselves before we start going through the topics on hand. So, Lucy, I will pass over to you first, please.
Thanks, Nick. So my name's Lucy Beishon, and I'm an NIHR academic clinical lecturer in geriatric medicine, and I'm based at the University of Leicester, and have an interest in frailty and TIA and stroke rehab.
Thank you very much. And Jatinder.
I'm Jatinder Minhas. I'm a Stroke Association Senior Clinical Lecturer and a UKRI Future Leader Fellow based at the University of Leicester, and a stroke physician based at University Hospitals of Leicester NHS Trust.
Thank you. And then finally, Terry.
Thanks, Nick. So I'm Terry Quinn. I'm the David Cargill Chair of Geriatric Medicine, and I'm a stroke physician, and I work in Glasgow in the UK.
Thank you. So now we've met the panel, I think probably the next step is to kind of go over the topic and to meet the topic. So Terry, I'm going to start off with you, please, which is, could you tell us what is frailty and why is it important to stroke?
Yep. Thanks, Nick. So frailty is interesting because it's one of those terms that as clinicians we all use. And I suspect we maybe use the term loosely, but really what's emerged over the last decade or so is a much more precise scientific understanding of what we mean when we use that word frailty. Now, there are lots of frailty theories. We may discuss some of them on the panel today, but they all have a common thread. So frailty is about systems not coping with a stressor, and that tends to be age-related. And if I move from that theory, from that abstract theory to the application in stroke, we can think of stroke as being an insult. A robust older adult is able to weather that insult, but in frailty, the outcomes that are associated with that insult of stroke are exaggerated. They're much more than would be expected for a person of that age. The other things I'd say when talking about frailty, because there are some misconceptions about it in the stroke field, it's not just age. Age is a very important part of frailty. There's arguments about whether you can have frailty in middle age. That's a different discussion. So age is an important part of frailty, but age and frailty are not synonymous. The other concept that often gets conflated with frailty is disability. Again, there's lots of overlap of disability and frailty, but they are different constructs. I guess the second part of any definition of frailty is, why is it important? Why are we defining this thing? Why are we interested in it? And I know we're a very biased panel here because we all have a clinical and academic interest in frailty. But I would say that the reason I became interested in frailty is because it's so common. There have been a number of epidemiological studies now looking at the prevalence of frailty in different settings, a lot of the literature coming from the acute stroke setting, and it's fairly consistent that about 1 in 4 people admitted with an acute stroke are living with frailty before their stroke. So this is not a niche topic by any means. I would argue that stroke medicine is frailty medicine. But of course, there are many other reasons why frailty is important in stroke, and I think some of the other panelists might want to comment on that.
Thank you, Terry.
Yes, so to add to the points that Terry's raised, we have a population that's growing older, with comorbidity, and this presents challenges. And as Terry's described, stroke is a stressor. It's a significant stressor event, and there are trajectories that individuals may be on before that stressor event, and things therefore change. And the reason this is such an important issue is that stroke has a significant economic and societal burden, and the ability to manage poor prognosis and to begin to think about how treatment may be either attenuated or perhaps indeed focused on the right individuals is frailty is a core component of that, and assessing frailty effectively will improve that. So this is a problem that's not going to go away. We've got burgeoning number of older people who are suffering stroke. For the United Kingdom, for example, the average age of those that suffer stroke is in the mid-70s, and these individuals will often have a significant degree of comorbidity and frailty present. I'll hand over to Lucy.
Thanks, Jatinder. Yeah, very much agree with everything the panel said so far. I think something that struck me from the work that I've done, so looking at frailty in TIA or minor stroke, is that the event doesn't have to always be that significant. And even in sort of quite minor events like TIA and minor stroke, we do see that frailty also has an impact on outcomes. Certainly locally in our TIA clinic, we've looked at all emergency admissions and linked their frailty scores and found they had a significant impact on mortality after even a TIA. So I think this is a really important concept to consider at all stages of the stroke pathway, and thinking about patients and how we move them through the care pathway as well, depending on their level of frailty.
Well, thank you. I think you've all made a very sort of clear and articulate point about the importance of the topic. And I mean, certainly from my perspective, Terry's mentioned about sort of 1 in 4 individuals presenting with acute stroke as having frailty. But actually, when you measure then into those that are on their way to becoming frail, those with pre-frailty, actually the burden expands quite dramatically. And in some cases, almost to sort of 3/4 of individuals having some degree of pre-frailty or frailty. And I expect that figure is likely going to rise as we see that aging population. So we have this sort of demographic time bomb on our hands, where frailty is going to play a large role in what we are going to be seeing coming in acutely to the stroke unit. Terry, I thought I saw that you had something there as well. Did you want to add?
Yeah. So the other reason that I was attracted to looking at frailty and stroke is that stroke survivors have told us this is important to them. So in the UK, there was a research priority setting exercise that was led by the Stroke Association and the NIHR. And one of the research priorities that came from that was an understanding of how frailty can modify the stroke journey. So that was coming from people with lived experience with stroke, and that really is very compelling to me that this is something that's important to stroke survivors. So it's a place that we need to be doing robust research, and we need to be looking at clinical pathways.
Thank you. And I think that is likely to be a theme that we're going to be coming back to in some of the subsequent questions as well, is that actually this is, yes, important for us as stroke researchers and stroke clinicians, but is also relevant to everybody involved in stroke, including those directly affected, the stroke survivors and their relatives. For those new coming into the topic, sometimes this idea of frailty, and it has already been alluded to, is it's almost viewed sometimes as a gut instinct that people have, that when they see an individual in clinic or from the end of the bed, they see somebody as being frail or not frail, having frailty or not having frailty. But realistically, how can we measure it robustly? And Lucy, I know you've done some work in this area. I wonder if you could sort of talk us through what your views are on it, please.
Yes, so there's a whole plethora of different ways of measuring or assessing frailty. So they range from doing a clinical assessment sort of face-to-face with the patient. Probably the best well-known of that is the Rockwood Clinical Frailty Scale. It can also be characterised in terms of phenotypes. And again, probably the best well-known of those is the Fried phenotype, which has constructs such as weight loss, feeling exhausted all the time, a reduced walking speed and poor hand grip strength. And those are all common things that I think geriatricians or stroke physicians see in their patients. There are also electronic ways of measuring frailty. So you can use a cumulative sort of deficit model where based on the sort of number of comorbidities that a person has in their health records, and that can be in primary care or in the secondary care healthcare record system, you can determine a frailty score, a level of frailty. Those tend to be used in the research setting perhaps a bit more, and also maybe in primary care to try and identify or characterise people who might be at risk of deterioration, or where you might want to start thinking about potentially advanced care planning and those kind of things. So I'd say the most common assessment that, and certainly the one that's become embedded in our hospital locally in our emergency services, is the Rockwood Clinical Frailty Scale. I think people prefer the face-to-face assessment, where you're able to really get a feel for that person, what they're able to do for themselves, how they function in everyday life. And it's also very good. It can be used as a sort of common language between specialties. So perhaps in geriatrics, we don't routinely frailty score patients as much because, as you say, Nick, we do perhaps more of an endobedogram assessment of the patient, and we're used to doing that all the time. But certainly when we're discussing with colleagues in other specialties or intensive care, they sometimes find it very helpful to have a common language in which we can conceptualise frailty and communicate with each other. And probably the last thing that I want to mention with regards to frailty assessment is the difference, and Terry touched on this when he discussed about frailty as a concept, is the difference with disability. So the modified ranking scale, I'm sure everyone is really familiar with, as a major trial outcome used in stroke studies. And there has been some interest in looking at whether there is an overlap or a relationship between the modified ranking and frailty, and sometimes they are considered to be synonymous. But as Terry said in the introduction, frailty really should be viewed as a different concept, and we can't just replace it with the modified ranking scale. I think we do need to be measuring frailty in its own right and separately to the MRS, and it will be nice to see that coming through, hopefully, in studies and trials going forward in stroke.
Thank you, Lucy. And I completely agree with that. I mean, I've been struck by the number of times where I've seen somebody that perhaps has disability but not frailty, and vice versa. And a number of studies have shown that whilst there may be some degree of agreement between them, actually it can be very variable, somewhere between a sort of kind of sort of correlation between somewhere between about sort of kind of 0.5 and 0.7, depending on what you're looking, or even up to 0.8 in some cases. But it captures something very different, I feel. So I completely agree with you. I don't know, Terry and Jatinder, what your views are on that.
I wanted to sort of add that there is sort of a bit of tension in the idea as to whether we should be assessing frailty from a sort of individual domain perspective, for example, thinking about sort of physical, cognitive, brain, structural change, or whether actually it's the total picture of combining these individual components together. And I think some of the studies have demonstrated a little bit of disagreement between pre-stroke frailty and stroke frailty assessed using some of these tools that Lucy's kindly alluded to, and when you separately look at the MRS, it's the fact that actually some components of dependency are well established on some of those tools and not on others. And so I think that as we move forward, we may get a slightly better perspective on operationalizing tools, and it looks, like there is certainly in the last 1 to 2 years a greater degree of assessment in different stroke subtypes, as Lucy's alluded to, in terms of more minor stroke populations, that we get a better idea as to how we use these tools across all of our stroke populations.
Thank you. You mentioned there, and I'm going to pass this over to Terry in a minute, but you mentioned sort of about the kind of different ways in which frailty may be considered. And, we've spoken quite a bit at the moment about physical frailty, but actually it leads us on then a little bit more to cognitive frailty and brain frailty. Terry, I don't know if you want to sort of talk a bit to that, please.
Yeah, I absolutely do. I think you can't have a panel talking about stroke, a brain disease, and not consider brain frailty. But I just want to come back to Jatinder's point, because I think it is fundamental. I hear a lot of people who perhaps aren't as convinced by the frailty concept say, well, you've got all these different ways of measuring it. They don't completely agree. Surely frailty is a nonsense. And I want to just challenge that. I think in any area of medicine, you have different ways of assessing things, and you assess things according to the purpose of the assessment and the resources you have. And that assessment can move from repurposing data that are already there, through to a screening or a triage assessment, through to a clinical formulation, through to the kind of very detailed phenotyping that you need for research. And that's standard. And the same exists in frailty. So these different methods for assessing frailty I see as being complementary rather than conflicting. And I think what I would encourage clinical services to do is to just choose the one that works best for their service and use it. So climbing down off my soapbox on that one, coming back to cognitive frailty. So frailty is a multi-system syndrome. And in the same way that it can affect physical systems, it can affect cognitive systems. Now we have a definition of cognitive frailty. It's a controversial definition, but it is a definition that we have that says cognitive frailty is the mix of physical frailty and cognitive decline that's not yet sufficient to have a dementia diagnosis. I think that's helpful to an extent, but I think what is more helpful is just to go back to basics and go back to that original definition of frailty, which is that the system doesn't respond well to a stressor. And you can think of in the brain as a system, if there is a stressor like stroke, it may not respond well to that, and that may manifest as further cognitive decline or slipping into a thing that we may call dementia, or other cognitive syndromes like delirium. All of those, to my mind, are manifestations of cognitive frailty.
Thank you. And I know there's very often a discussion about brain frailty in terms of sort of radiological appearances. But could you enlighten us about what the characteristics are of those?
Yeah. So one of the theories of frailty, and there are different theories, but again, I would argue they're complementary, they're not conflicting. One of the theories of frailty is of cumulative deficits, insults to the system that have accumulated over the lifespan, and each one makes that system more vulnerable to the next insult that comes along. And on the brain, we can see radiologically historical evidence of various insults. So you may see stroke disease, you may see silent stroke, you may see evidence of old traumatic brain injury, you may see cerebral small vessel disease, you may see atrophy in a particular distribution that might suggest a neurodegenerative disease. And each one of these things makes that brain that little bit more vulnerable to the next insult that comes along. And when they're present cumulatively, that vulnerability just increases and increases. So there's no magic to brain frailty. You're just using the scan that you order anyway as part of routine stroke care. You're looking beyond the acute stroke lesion to see what other evidence is there that this brain may not respond so well to the stroke that's in front of me.
Great, thank you. And Lucy, I just want to pick up on something else that you mentioned, which is about the timing of assessment. But one of the things that I often encounter is the understanding of when you are assessing frailty, what time point are you looking at for the individual? Are you looking at them when they're there in the hospital bed, or are you looking at much more of the kind of background to where they are? Could you comment on that, please?
Yes, so ideally you want to be assessing frailty from before the hospital admission, so not in their acute admission. Most older people, when they come into hospital, if you scored them there and then in the bed, they would come out as highly frail, but it's not reflective of them at their baseline prior to their hospital admission, and it can lead to inappropriate decision making. And that is something that we have sometimes seen in clinical services if there is a misunderstanding around that. So it's really important that it's done on the pre-admission state of the patient and how they were usually more than 2 weeks before that hospital admission to try and capture that baseline. Obviously, if that person's been declining for some time, it can be challenging to, again, decide when you should do that. But is that decline as a result of, an underlying cognitive impairment that means that that's going to continue to progress, or is it something that's, more of an acute reversible illness that where you might be inappropriately frailty scoring somebody if you do it too close to the hospital admission? So it is really important to consider the timing of your assessment as well.
Great, thank you. And I'm going to throw this open to the whole panel now, but when sort of either in your research or in clinical work, what factors make you decide, am I going to consider CFS or a clinical frailty scale in this instance? When would you use a frailty index? What are your thought processes either in, as I said, clinical work or in designing research?
Well, I maybe start. So, Nick, I'm a pragmatist. If I'm working with a research data set and it has sufficient data to allow a frailty index to be calculated, it would seem intuitive to me that we want to do that. if we're looking at data on older adults, we've already discussed how important a moderator of outcomes frailty seems to be. It just seems a no-brainer to me that you'd want to look at frailty as part of the baseline descriptors. In clinical services, we're all busy. Every clinical service is extremely busy. The amount of stroke work just increases and increases. So we can't ask clinical teams to start doing research level frailty assessments. We need something that's quick. We need something that can be done by any member of the team. We need something that has training available, but it doesn't require lots and lots of training. And in our service, we have tended to use a clinical frailty scale that Lucy spoke about earlier.
Yeah, just to sort of add add to that message, I think standardizing the recording of frailty assessments within your institution, whether it's stroke or non-stroke, also enables a culture of understanding how that tool functions, enables and empowers other members of the multidisciplinary team to be able to perform those assessments. And importantly, if you're collecting it from the outset, or ideally you've got, as Lucy's mentioned before, pre-stroke data as well, you can track that. Patients often end up being readmitted. You can look at the trajectory and change over a period of time. And so, for example, in our setting, if you're over the age of 65, then you will almost certainly trigger an immediate assessment as part of your initial admission clerking. But as we know, age is not necessarily strongly correlated with frailty, and there are individuals under the age of 65 that have frailty assessments that can be tracked as well. The difficulty is as you've got the interfaces of care, for example, on the stroke pathway, and you move from inpatient care towards rehabilitation hospitals and beyond, how do we ensure that the recording continues, and also how do primary care utilize those tools in, for example, advanced care planning and other things? And I think that there needs to be some implementation work, certainly in the United Kingdom, around how that gets carried forward and tracked. But clearly data is very powerful if it's collected through the entire stroke pathway.
Thank you. And I would agree with that. In terms of data being powerful, fortunately, we work in a field where there is a lot of data generated across the multidisciplinary team. So to declare my preference, I very often do use in the research setting a frailty index. And the advantage of it is it captures the data from across biochemical results, across functional results, across comorbidities. But it takes the time, and I suppose a challenge for us in the field is the number of different frailty indices, the numbers of slightly different ways of approaching it can sometimes make it very difficult to compare one study to the next. So I don't necessarily expect the panel to answer this question, but a thought that I know has been raised is, should we be working towards a standardized frailty index for use in stroke? That means that we can then compare populations and compare and facilitate meta-analysis across a number of different studies. As I said, I'm not expecting anybody to come to a definitive answer, but I don't know if anybody has any sort of closing thoughts on this aspect of the question.
I guess going back to Lucy's point, I think a little bit is also thinking about clinical trials and our current endpoints. There's been a lot of research, for example, on whether the MRS is the be all and the end all. Is that the answer to where we are? And things like time at home, or sort of related to the speed with which you can be discharged, or indeed using perhaps frailty endpoints. I think this question remains fairly open, but in order to perhaps think about how well some of the treatments we deliver are kind of changing the outcome, or indeed improving the outcome for the better, we've got to think about having frailty as a sort of a recorded process through these trials, and I'd love to see future clinical trials being empowered to consider frailty as part of the inclusion, exclusion, and also carried forward all the way through the trial.
I wonder if I could just come in. So standardization is always powerful. Standardization removes variation. and allows you to compare things. It allows you to pull data. So I'm always in favour of standardisation. I've seen some real crimes against frailty committed under the auspices of a frailty index, with people putting in values that really aren't related to older age and aren't related to system decline and shouldn't be in a frailty index. So I would just point out that Ken Rockwood and his team have made a how-to guide with best practice on how you create a frailty index. And I think if we are going to move to standardization, we should be looking to emulate that best practice.
Great, thank you. So I think we've already started moving into this a little bit more about, kind of how are we going to operationalize it, but also why are we looking towards operationalizing it, both in a research and clinical setting. So my next question then leads on to is that how do we anticipate frailty affecting either trajectories or treatment decisions in both the acute and rehab settings? Terry, I know you've got some thoughts on that. Do you want to tell us what you think on that one?
Yeah. So again, believe it or not, there are people that don't buy into the frailty concept in stroke. And another argument that I hear frequently is that by assessing frailty, we can be guilty of a therapeutic nihilism, and we may use frailty as a tool to deny older adults treatment. And again, I want to challenge that, because although we have clinical practice guidelines, we're not automatons. We make clinical decisions on every patient we see, and we make those decisions in a patient-centered way. And we consider how we think they're going to react to the interventions that we're going to give. And what I see frailty doing is just formalizing and standardizing that assessment. And going back to some of the points that Lucy made before, it gives us a common language so that other people in the team can understand that assessment. And it also allows us to quantify things. And that's important, not just from an academic point of view, because I don't see frailty as being a binary present or absent. It exists across a continuum. And by doing the assessment allows us to really give that gradation and understand the various levels of frailty that might exist. But it's a really important question to ask, Nick, because I know it is a contentious issue, and I suspect others on the panel might have some thoughts.
Well, that leads on then. Lucy, Jatinder, thoughts from yourselves?
Yeah, I mean, I think I definitely agree with that point, and I think one of the sort of challenges we've got is kind of thinking around if we're going to operationalize frailty, we kind of also need to answer some of the questions that those that criticize its presence have. For example, how confident can you be that frailty models linked, for example, to the lack of physiological reserve? So if you are very frail, how much reserve is there, and therefore how resilient is that individual likely to be in the face of certain treatments? And we know, for example, that where disease is often severe and has a high morbidity or mortality, for example, intracerebral hemorrhage, this nihilism exists because we believe that we're perhaps unlikely to secure a good outcome. But actually, simple interventions like bundled care in ICH, for example, have led to a revolution whereby we now understand that mortality can be reduced, whilst that still may associate with some morbidity and dependency. Understanding how frailty also is a modifier in these instances is absolutely crucial. So I think what we haven't yet got to is population level studies around frailty, and thinking about on a sort of national scale, if we are going to implement and standardize the use of a particular tool, how does that impact overall outcome for particular diseases? But I think we have got a little bit of a way to go still to convince some people that these tools are robust. But increasingly, they're the best way to kind of think about some of the terminology that gets bandied around in terms of disability, dependency, multimorbidity, frailty. These are quantitative measures that take away some of that subjectivity, and that can surely only be good.
Hi,
Lucy.
I was just going to sort of build on what some of the things that Jatinder and Terry have said there, which is that So we know from the studies in stroke and the recent work we've done in TIA that frailty is extremely prevalent in these populations. And I guess there's a consideration that the presentation with the stroke or the TIA is a reflection of the frailty of the individual as well, and the fact that they're presenting because they're vulnerable and that stressor has unmasked that perhaps. And then I think that does potentially need to frame some discussions and decisions around perhaps some of the things that we're often doing in TIA clinic around secondary prevention and further investigations and what may or may not be appropriate for individuals depending on their preferences. And I think frailty scoring people in that situation can help with framing those conversations and discussions as well, and also identifying patients perhaps where we want to either be more or less intensive with treatment. And then I just wanted to touch on rehab, and I think this links quite nicely with the discussion that we've often seen in general geriatric medicine outside of stroke care, which is around rehab potential and labelling people as not having rehab potential. And again, this has been something that's been quite heavily debated, and I think frailty is quite important in that, but it's particularly relevant for stroke services because rehabilitation obviously plays a huge role in managing patients post-stroke, and who goes to rehab and who gets rehab is can be a problem, and whether frailty moderates that, decides on and feeds into those decisions about who goes to rehab and how much rehab and how intensive that is not something that's really been, I don't think, looked at very well either in clinical services or from a research perspective. And I think we need to do a lot more about thinking about how we integrate frailty not only into our assessments and scoring, but how those frame our treatment discussions and decisions with patients as well.
Thank you. I think that's such an important point, is that we have this information available that may potentially improve our prognostication, our shared decision making. It seems unwise not to use that. I would echo what Lucy's just said about in the rehab setting and avoiding this treatment nihilism, as Terry puts it, of there have been a number of studies that show that for individuals with frailty may not have a benefit with some of our standard interventions that individuals without frailty continue to benefit from. I think sometimes there's a risk of missing the point there, though, because does that indicate there that somebody is not going to benefit from anything full stop? No, we don't know that. But actually, should we be looking at how we better tailor the interventions for an individual who has both stroke and concurrent frailty at the same time? A number of specialties have started doing this, with cardiology being an example, where, for example, rehabilitation after heart attacks or after heart failure factor in, yes, the rehabilitation of from the heart perspective, but also as well targeting frailty as part of that. And do we need to be looking at that in stroke? I think it's a very important question, and ensuring that we're not then turning around and saying, well, there's no evidence, or there's evidence that indicates there's no benefit. Actually, maybe we're just sort of failing to adapt our treatments and our interventions to this different population, rather than treating everybody in a uniform fashion. My other thing, now that I'm on the roll about it, is about the hyperacute side, because this is sort of a particular interest of mine, which is, again, a number of studies have looked at age, and very often the modified Rankin has been used as a way of eligibility or ineligibility to hyperacute studies. But as we've said, that doesn't capture frailty. And more emerging evidence indicates that frailty does appear to have a treatment modifying effect in our reperfusion therapies of thrombolysis and thrombectomy. However, it's not a binary thing, and frailty comes as a spectrum. And I do worry that there are some individuals who are a little way on the frailty spectrum, but not necessarily have reached a frank frailty yet, where they may continue to have some benefit from these acute reperfusion therapies, admittedly attenuated, but are being not enrolled into studies or not being considered for it because they are viewed as being too frail. And I think we need better evidence to be able to come to sort of more robust decision making on that. So that's hopefully some area in the work that we can work towards in the future. Thinking about that, any other thoughts on how frailty may affect treatment decisions, either in any of those settings? We haven't touched on secondary prevention. I don't know if anybody's got any thoughts on that.
It's I recall some interventional studies, for example, around carotid revascularization that have identified that in sort of large numbers of individuals, I think there's a study over 1 million individuals whereby about sort of 60,000 were frail, that frailty itself was independently associated with post-procedure mortality, stroke, MI, etc. And so therefore, going back to your point earlier, Nick, about the adoption of frailty scores within other areas of medicine, surgery to enable decision making, I think it's important that we understand that there is large scale data that's demonstrated that perhaps some interventions may not necessarily be beneficial for some populations. But let's also remember that a lot of the trials that were done did not always necessarily include individuals of older age in the past. And for example, the statin trials, the blood pressure trials, and actually there's also the concept that those with the greatest risk sometimes have the greatest benefit. And I think going back to the point around nihilism is we perhaps do deny individuals certain treatments because we feel like, perhaps their lifespan may be 5 years, 10 years, and therefore what are we trying to modify? But actually there is arguably a large potential benefit in that first 12 months or 2 years that we need to think about. And I think some of the secondary preventives with statins, DAPT, I think is another example where sometimes we can be a bit nihilistic, but actually there's fairly convincing data that it's beneficial in the right populations. But I think there are still areas of clinical stroke care where we could do better at understanding. So I mean, a good example is we utilize the MRS to make some decisions around mechanical thrombectomy, but actually if those trials had included CFS as for example as one potential tool to enable decisions, would more patients who may benefit from thrombectomy go through? So I think it's interesting to think about how some frailty tools may replace the MRS in the future, particularly in hyperacute therapy decision making.
Thank you. I think also, sorry, Terry.
It just made the decision. I think what's coming across from the responses that you're receiving from all of us is there is some equipoise here about how we should use frailty. I think we're all on board that a knowledge of frailty is powerful and is more useful than not assessing it. But there's an uncertainty as to what we should actually do with it. And I think that's where we need research. It's where we need data. Because at the moment what we have are opinions. And opinions shouldn't be what we base our clinical care on. It should be based on data from robust clinical research. And I think it's quite exciting that there are trials happening now that are starting to look at these questions. And when I think about secondary prevention in older adults, I think about it in both ways. I think about starting things and stopping things, because a lot of physicians will, in a well-intentioned way, stop every medicine when someone reaches a particular age threshold. And actually, we don't know if that's the right thing to do or not. But there are trials.
Just on that topic, Terry, do you think that there's also some work to be done on the way that the language we use to frame this for patient populations? Because for example, thinking about the idea of brain frailty, that we are determining an element of vulnerability, and that may be through, for example, terminology like furring, which I tend to use to describe a degree of small vessel disease. But it's also how I think patients benefit from understanding that they may be on a trajectory towards something, and I think also how we utilize some of the frailty tools to describe where that patient is at that particular point in time is also helpful. And there's that well noted diagram that was included in one of the review articles published by some of those on the call today that sort of explains a little bit about the impact that frailty has on treatment trajectories. And I sometimes feel like if you're frail and you had a stroke and you do manage to leave hospital, it's sometimes important to frame that actually your reserve, should you have a recurrent stroke in the future, is extremely limited, and therefore the risk of long-term dependency and or death is certainly there. But I don't know how well we have those conversations.
No, and language is so important. And I think there's a PR issue with frailty. From some of the work that we've done with older adults, and it's been echoed in work from other groups, older adults never perceive themselves as frail. They see the importance of frailty, they see that other people are frail, but they don't want to be frail themselves. And so we just need to think, I mean, do we use the F word? Or do we frame it in a different way? And I'm not sure. Again, I think there's research to be done there.
I was just going to add to what Jatinder and Terry have said about, I think it's really important to consider this in the context of the patient's priorities. And although frailty in itself maybe shouldn't preclude a particular treatment, the patient's priorities may change as their frailty progresses, and what they want out of life and their care may change as well. So I think it's really important to use frailty, but within the context of what's important to that patient. I think statins are often the one that get the really bad press in older people, and the geriatricians have seen to be striking them off the drug chart. But I think it's important to consider, the level of polypharmacy that patient has. Are they struggling with taking all of those medications each day? What are their symptoms, and which medications are going to benefit potentially symptoms rather than perhaps the secondary prevention? And I think there's an awful lot of other things that go into the factor and the consideration, and we do want to be careful that we're not just using cut-off frailty scores or ages to make those decisions, and that we're actually framing it in the context of the patient and what's important to them as well.
I think that ability to tailor information, to be able to incorporate then the individual's views of what's important to them, is key. When we speak to stroke survivors across a range of different sort of frailty measures, very often, I agree, very often there is a perception or that an individual is not frail, but actually very often recognizes that somebody is getting older, and people will often refer to themselves as getting older, but very often a lot of the characteristics that they are discussing are actually criteria that you use to define frailty. And when it comes to then hyperacute decision making, the number of people that we have spoken to that said, well, I realize that I am perhaps older than I was, I am perhaps less robust than I was, but actually, even if I can still get some benefit, albeit attenuated, from one of these treatments, I would not want people withholding it from me simply because I am that bit older, I am frailer, even if then there is a sort of a increased risk of complications. I think being able to have that data to hand, which I don't feel we have sort of good, robust data on that front at the moment, I think is going to be key to being able to have those more informed discussions and being able to kind of reach a shared decision and a better, more informed decision at the time. So I suppose that leads us on then to our final question, which is what's next? So I'm going to throw this one over to Jatinder to start us off. Where do you see the field going, Jatinder?
So I think we're at an exciting juncture where we've got sort of pockets of research ongoing, perhaps into different aspects of frailty. So I think we've got a burgeoning amount of literature that actually is arguably probably more in the non-stroke domain, looking at systemic frailty as a whole. We've got, and that's both in primary and secondary care. I think we've also got some focused work within our communities looking at neuroimaging and trying to determine markers of brain frailty. And I think, we've got sort of the classic things that we have a greater understanding about: cortical atrophy, deep white matter hyperintensities, etc. But I don't think we've quite understood how that also marries up with some of the other conditions that we've got, for example, cerebral amyloid angiopathy, thinking about also the spectrums of cerebral small vessel disease. So what I'd love to see, and I think we need more work on, is marrying the brain phenotypes which are in the era of advanced imaging, we've got a much greater understanding of. And there's some fantastic studies from colleagues up in Scotland that have really tried to look at this in detail, both in trial and non-trial populations. And then we've also got the systemic frailty, and I think we need to bring those two together. How close do they marry up? Is there a phenotype that can coexist that's quite predictable across both systemic and brain frailty? And if we put that together, how do we utilize that when we assess patients, both from a pre-stroke perspective and how far post-stroke can we be confident that we can then reassess where somebody is? And I think that's one of the challenges about using some of these indices within trials, is that how long does it take to then go back to the idea that there's a fair enough period of time to reassess somebody's frailty? And I think that remains a little bit unclear. But I also would like to see a great deal more research looking at the subtypes, and I think there's been some work now, as Lucy's mentioned, in milder stroke subtypes, and also in ICH, which is fantastic to see. Perhaps also maybe some more work in chronic stroke populations, months to years down the line as well, to see what would a sort of mid-range frailty or a latter frailty score look like. Is it really all entirely pessimistic and poor outcomes? So yeah, it's a really exciting space to be in, and marrying that with some mechanistic work would be lovely. Think particularly things like using transcranial Doppler ultrasound to look at cerebral blood velocities, cerebral autoregulation, thinking about mechanistic processes, and yeah, bringing that together, multimodality studies.
Thank you. I think that mechanistic side, to me, is a big area for us to develop, because I think, as we've already discussed, we're getting a better understanding all the time of sort of how frailty can impact outcomes, but we don't necessarily understand why or how it influences outcomes. So in my mind, there's some very interesting data that looks at frailty and being a systemic inflammatory state, the effect it can have on the brain as part of that, as you've already alluded to. Other roles as well of frailty being related to sarcopenia in the rehab setting, about blood flow, cerebral autoregulation, all these kind of multi-system effects by which the body can influence outcomes in stroke that are then affected by frailty. Yes, we can have a better understanding of how then frailty impacts stroke, but even more exciting, does that yield then the possibility of us being able to intervene in some fashion, either sort of before or around the time of stroke? So I think I would agree, marrying the mechanistic side then to the observational data that we've seen would be really interesting. Lucy, what would be on your wish list?
So certainly I'd like to see a bit more about how we use and embed frailty assessments into clinical services, and looking at how that does some of those things we've been discussing about. So how does it influence treatment and decision making? How does it frame the way we have conversations with patients? How does it affect who goes for rehab, how well they rehab, and also thinking about maybe on a bigger scale about how we can organise services and streamline care for patients, and how we can factor frailty into our services to make sure that our services are frailty friendly, perhaps. And also that we're considering the holistic aspects of patient care and not just the presentation or single organ issues and things like that. And I think frailty as a concept could be really useful in how we do that. But certainly, I think it's being at the moment applied quite heterogeneously, certainly across the UK and I'm sure internationally as well, in different clinical settings and services. And I think looking at how we can better utilise and embed that to support both us and our patients in decision and care making would be extremely useful.
Thank you. And Terry?
So, I mean, first, I just want to echo Lucy's point, because I think she was spot on. We've got a real implementation gap here. And this is unusual for stroke, because stroke medicine is traditionally a very evidence-based specialty, and we have a lot of research that underpins what we do. But actually in the field of frailty, stroke is lagging behind lots of other disciplines. And I think we need to learn from other disciplines, and we need to look at how we implement that in clinical care. The other area that I'm particularly interested in is really the flip side of frailty. In the same way that a person of a certain age can have a poorer outcome than you might expect for an insult, you also have people who do really well, and they probably have this concept that we may call resilience. And actually, where my research team are moving at the moment is starting to look at resilience and, what predicts that and what actually is the mechanism that seems to underpin resilience.
Thank you. And just picking up on that, then, would you consider resilience as the flip side of frailty, or is it different?
To say flip side is maybe an oversimplification, but it's moving from a deficits-based approach to an assets-based approach, is how I conceptualize it.
Thank you. So I think we're coming towards the end of our time. Any other sort of closing thoughts from anybody?
I think just to say that there has been a disparate approach to this, with gerontologists, some stroke physicians, primary care physicians working in relative silos. And I think one of the refreshing things about the opportunity that was provided through the Cerebrovascular Diseases special, article collection is that it's given us all an opportunity to perhaps converse a little together and provide some literature that links to some of the areas that have been less well represented. And it's refreshing to see the quality of the submissions and the breadth of work that's been brought to our attention. And I'm grateful for all the colleagues on the call who have enabled that through their assistant editorship and contribution to peer review. But the exciting thing is that it provides a one-stop shop for colleagues within the stroke area that wish to understand more about this field, have a look at perhaps some of the topic areas that are of interest currently to an international audience, and begin to think about some of their own research questions. And so hopefully through that there'll be the opportunity to look at the key literature within the area. So I would like to signpost everybody to that, and consider also engaging with CARJA colleagues who'll be present at the European Stroke Organisation conference later this year, and also feel free to contact us as a group or individually to discuss any ideas further.
So thank you. I think that's an excellent note on which to end. I think the field is exciting, it's expanding, and is incredibly important. And I thank all of you for the discussions about highlighting these areas of the topics, not just only sort of what we have achieved so far, but also where we're going. So on that note, I want to thank Lucy, Terry, Jatinder, and all of you for listening as well. Thank you very much.